Hi, eGP learners, and welcome to this episode of the eGP Learning Podcast with myself and
And Dr. Andy Foster here as well. Love the new countdown, Gandhi. That looked very professional.
thank you. And we hope you're enjoying this kind of new look that we've got. We've been trialing it over the past couple of times and stuff, and we're using some new interesting software to figure out how this goes. But yeah, we've got an interesting episode for you guys because we're going back to our roots. We're talking about some digital articles and one in particular about Babylon over in HTN. So feel free to check out that in a short while. And also we've got some interesting news for you as well. So we've got some reboots of our tried and trusted event that we've been running previously, as well as a big, massive announcement about something that's coming up at the end of September as well. But how you been doing it, Andy?
Yeah, I'm good. Busy. Lots going on in the primary care network world. Aligning care homes sometimes generate controversy and headaches, it seems. But yeah, generally pretty good. How about you, Gandhi?
Yeah, it's been busy. As you mentioned, PCM work is definitely, I think, keeping both of us very busy with the care homes and us obviously trying to get all our plans in for the allied roles and all that kind of stuff. In addition, actually got loads happening with eGP Learning. So various different things. On the 24th of August, we'll be doing a remote consultation 5-day challenge with Dr. Ed Pooley, who some of you may know from Difficult Conversations. He's been running some really successful work there. So we're doing a collaboration together to try and support general practice. Been speaking at a few things recently, and we've got demonstrations of various products, including, for example, Clinic that we're showing on Wednesday, and leading up to our Digital First Primary Care Guide number 2. So the second time we're doing this, and I'll be on the 9th of September. So definitely make sure you join us for that. So lots of stuff coming up for all of you, and hopefully we find that useful. But yeah, we are live. We forgot to mention that. So if you are watching us, and thank you for doing so, make sure you say hi as well. So we are keeping our eye on the comments and stuff. More than happy to know what you guys are thinking. And we've got some cool questions for you as well. So do keep an eye out. I've got a couple of things I wanted to ask you throughout this stream. So definitely, if you are watching us live, say hi, say where you're from. We'd love to hear from you. But we've got a nice article, haven't we, Andy, to kick us off?
Yeah, so I'll cue this up on the screen. So friends over at HTN have run an interesting article about Babylon. Babylon, a company that's come up quite a lot on the podcast in the past, hasn't it? And prior to COVID, we used to spend a bit more time talking about some of the sort of bigger technology trends and concepts like AI and video consultations, although they've become a little bit mainstream and potentially humdrum more recently. So I thought this was a really interesting article from Babylon. The title is Babylon publishes research report on AI in primary care. So what they're talking about is a paper that they've published in Nature Communications titled Improving the Accuracy of Medical Diagnosis with Causal Machine Learning. Now, also on the screen, I don't know if you want to show it, Gandhi, we've got the actual paper, and we both had a look through this and attempted to read it prior to the show. It's really complicated paper. So if anyone fancies, diving deep and then coming back to us with some comments about the methodology, that would be great.
Yeah, I mean, I'd definitely love to know what people like Dr. Tricia Greenhalgh and Margaret McCartney and think about this, because to be honest, a lot of the content, particularly the nomenclature and the wording, went a little bit over our heads, didn't it, Andy?
It did, but some of the fundamental ideas and concepts I think are really, really interesting. So the problem they identified that they were seeking to move forwards with on this was that that deep learning generally works by looking for associations and correlations, and diagnosis as performed by doctors generally works differently. It's deductive reasoning and causal reasoning. And what they say is they were finding that their deep learning algorithms using this sort of correlation model were performing about as good as an average doctor in their tests, about at the 50th centile. And they wanted to try and improve that. And actually, by applying this new method within the context of this study, which again may be limited, may not be reproducible, generalizable, it's just one study with a certain methodology, but they found that they were able to increase the accuracy to the top 25% percentile of doctors, which I think was a good achievement. So what they did was sort of pose, they said they reformulated diagnosis as a counterfactual inference task. So I think really what they were talking about, and the HTN article demystifies some of this, is they were asking a different question, or an additional question, saying, would this symptom be present if this was a different disease to the one that was inferred by the correlation? So essentially they were giving the computer the tool to keep an open mind, which I think is a really interesting idea. And they were including that opportunity for the AI into the algorithm. So I don't know about you, Gandhi. So I mean, I know when I was taught about diagnosis, and this is more about how to perform in exams. I remember this from medical school, and it's something that I often tell students as well, particularly those that are lacking confidence when they are getting to their differential diagnosis part. You know, years 1, 2, 3 students that are very good at telling the history back to you, and then they sort of stop. I'm sure we all find this when talking to medical students, and sometimes they need a bit of a framework to help them just begin to get confidence proposing a differential diagnosis. And I tell them, think about what the most likely diagnosis is, or the top, you know, or the 1, 2, or 3 likely diagnoses that it probably is, and then think about what you really don't want to miss. What could it be? What's possible, but you really don't want to miss? And then think about something rare, if you can, and say that, and just pose that as your differential diagnosis in that way. And you can you use the same knowledge that you've got, and you might have not looked very smart if you just propose 1 or 2, but using a framework, you can use the same knowledge and you can propose and deduce a lot more. So reading this article, I was thinking it's almost coaching the AI in that way to just keep an open mind and think about what else could this be. I know what is most commonly associated with this cluster of symptoms, but what could it be? So that was interesting. I thought it was asking the AI to take that approach. What do you think, Gandhi?
Yeah, I mean, I think the paper looks at this concept that, as you mentioned, when it comes to coming up with diagnoses, a lot of it is based on correlation. So a patient will give us symptoms. We then try and formulate that into the various understanding of what their symptoms are, into what it could be, and balancing that with the patient elements. So like the demographics of the patient, the history of the patient, you know, things that have happened to them in the past, medications they maybe, all those kind of things go into this complicated process of trying to narrow down the possibilities. And like you said, common things being common, there are often, you know, a couple of things you can normally think of. There's always inevitably some things you worry about, that it could be this, and how realistic is that? But I think the challenge for many clinicians is coming up with those rarer kind of things, because we don't see as much of them, but also with that, because they are rare, you don't anticipate them being the first thing you need to be thinking about or worrying about. I guess part of what this study is suggesting is that this potentially is a tool of helping to understand what some of those more rarer things that we don't see as much of could potentially be, and are they likely to be a factor? You know, are they? You know, how much more likely are they? And I think that's really useful. I mean, we've talked about machine learning and AI learning in the past, haven't we? And where we see, you know, this having an impact on general practice. We've always felt that, as good as GPs generally are, it's hard to remember everything. It's hard to process everything because there's so many variables. I mean, if you look at the number of conditions that can cause a cough, most people think things to do with lungs as your first port of call, but actually cough as a symptom can be caused by your lungs, can be caused by your heart, can be caused by your stomach, can be caused by, you know, I've even seen cases where it's been caused by skin, you know. So it's trying to rank where all those different things fit in. And I think anything that helps with that is always a potentially useful thing. But anyway.
I think so. So just getting to the science bit and just looking at what they actually did for those people who will be interested in that. And we all should be, because we should never take these studies at face value. So they created some written medical cases. So they used their staff of GPs. I know, talking before, we were thinking, well, maybe they had a little bit less to do during the COVID crisis. So making good use of people potentially. But nonetheless, it's a good study. So they had 20 of their GPs create, they said, about 1,600 written medical cases. And then they took 44 of their GPs and got them to process these written cases, read them, produce a differential diagnosis. And most of them did. None of their GPs processed less than 50, and the average number that was processed by each GP was 159. And then they gave the same written cases to the AI. So obviously, they're being given in a format that the AI can easily understand. So I've not seen an example of these written cases, but they're obviously not taking a history from a live human, because that can have a lot of challenges, as we know. I'm just mentioning that because you can sometimes look at the headlines here and say, oh, this AI performs better than 75% of doctors, but it's receiving, written factual information. And often the challenging bit is getting the information out of the patient and actually determining what they mean by what they're saying, and actually codifying that as symptoms. So some of the work's already done for the AI here, in my opinion. But that's what they did. Then they compared the outcome, and they found that the AI performed better at including the correct diagnosis in the proposed differential diagnosis for the symptoms, and performed better than 75% of the GPs in their sample. So it's interesting. And their old model that they also tested performed better than 50%. So that's what they actually did. I mean, how significant do you think this is, Gandhi, in terms of a...
Like you said, I think that inevitably the devil's always in the detail. It'd be interesting to know whether or not the AI was producing a list of 100 different conditions, and that's why, therefore the pickup rate was potentially higher, because generally speaking, most doctors and stuff won't come up with more than about 5 or 6 tends to be the common kind of, differentials when you're thinking about things. So it'd be interesting to see how that works out. But I think any tool that can help you understand potentially the rarer things, because as we mentioned, common things are common, but rare things still happen. I think that's the important part to remember. And part of the challenge with the diagnostic process that we generally have with general practice is that it is harder to pick up those rarer conditions earlier on. It's not impossible. But, for the rarer kind of things, often it's normally the second, third, or subsequent consultations that, you will likely pick up those rarer kind of things, unless you've got a very, very good reason, i.e. previous patient history. So if patients have previous cancer, your risk factor for them thinking, have they got cancer on a second presentation, clearly much higher because of that association. But then, it's that clinical reasoning, which is a true art.
Sometimes it's the experience of the doctor, isn't it? Sometimes if you have seen a case of that before and you've seen it live and in the flesh, you're more likely to pick it up if you see it a second time. But with these rare things, we're often given those stats, aren't we, that you will see one of these in your career, or you will see 3 cases of this rare disease in your career. And this is where doctors might not see any cases in their career. The average doctor is going to see 3 cases. So their chances of having seen it before and having a better experience of how that presents in the flesh is pretty low. The good thing about AIs, I suppose, is that they just see so many more cases. They're an aggregate of the experience of everything that AI is doing. So for Babylon, I guess it's every interaction that takes place on their platform contributes to their AI's understanding. So I think you're right. For the understanding of rare diseases, this is something that can be potentially really useful. And I think almost the current system accepts that rare diagnoses take longer to make. It's almost accepted that it's, well, okay, we're seeing you on the 5th occasion, and this is when, or you've seen the specialist twice, and now this very rare diagnosis is being considered. And we almost accept that because we accept there's perhaps an element of elimination, trying treatments for other things, and that's true. But perhaps this can just speed things up a little bit and reduce that time to rare diagnosis, and that would be really, really good. So the other thing that was interesting, I thought, was some of the comments, just sort of going back to the HTN article. There's some comments from Babylon staff. So Ali Parza, CEO of Babylon, said, this should not be sensationalized as machines replacing doctors, because what is really encouraging here is for us to finally get tools that allow us to increase the reach and productivity of our existing healthcare system. Now, I've not sort of gone digging for quotes, but I remember a few years ago, there were what I would consider quite sensationalized sort of quotes from the same person in particularly one Financial Times article where he was talking about doctors being replaced by AI and things like that. And perhaps at that time, you're perhaps wanting to shape investor attitudes towards the company and its potential for making money in the future. But it's very interesting that he sort of changed the focus a little bit and is now making much more collaborative noises about not replacing professionals but supporting them. So I think that's really really
clearly we're speculating, and I think, like you said, it's a difference in tone. I think that we have previously seen from some of the stuff that seems to come out from Babylon in terms of what they're talking about, but definitely agree. A different kind of attitude seems to be present in this particular.
And hey, it's good. It's
good.
Nice. And I'm much a fan of Babylon. I think disruption is a positive force, generally speaking. They've been disruptors in primary care and in healthcare, and bring it on and let's have more of it. But it's nice to have a more collaborative tone, which is really good. So, and the other thing as well, so they're also saying other things about it. So they're talking about supporting doctors, reducing misdiagnoses, which I think is something that we were identifying. And I thought that was great. And there are a few other comments in there. AI will be an important tool to help us all end the injustice and the uneven distribution of healthcare and to make it more accessible and affordable. I think that's great. I think Babylon have always said things like that actually about their products and the impact that they might have in under-doctored areas around the world, or under-doctored communities. And I mean, heck, there can probably never be enough doctors. There is just so much demand, even in this country, for access to healthcare and appointments with general practice and other doctors. So every little bit helps, and I don't think the profession should feel too challenged, because it seems like it's an insatiable thirst for our attention. But I think it's really nice that they're looking at these sort of social and economic injustices.
Definitely. And I think that's part of the challenge, isn't it? We're moving towards an area where we're looking more at population health, aren't we? And taking into account those variables about, things that you may not always take into account because you don't have the metrics to help you with that. So, patient demographics, linking up. I mean, these systems could easily link up with population-based data to give you more of a prevalence of things like, for example, HIV, a condition that in some areas is actually considerably more prevalent than people wouldn't recognize. And actually, is that something you need to think a lot earlier on, potentially in the diagnostic process, just because of the area that you work or live in? But you may not be aware of that because you don't have that data to support that kind of information.
Yeah, or you might not work in that area all the time, or you might be working for a video GP service as a doctor, and just happen to be connected with someone from that area, and you don't not even aware of those issues in that area or those communities. So I think it can be really helpful with that. So Gandhi, I sort of see a future here. So I like to think, where could this potentially go? And I'm seeing a future where I'm sat consulting, and there's almost something running live next to me, maybe with some natural language processing, picking up on what's going on, or perhaps before we get there, the patient's done some sort of pre-consultation assessment, and there's an AI sort of sat on my shoulder a bit like a guardian angel, just sort of guiding me, suggesting things that might be less common to think about as the consultation evolves, and reducing the chance of a misdiagnosis, increasing the chance of getting the correct diagnosis earlier, particularly rare diagnoses, and almost freeing up a bit of my headspace to concentrate on where I can still add value in terms of kind of decoding what some of those patients who find it more challenging to describe their symptoms are actually driving at, and then thinking about personalizing the management plan for that particular patient and their circumstances, and making some of those complex judgments, which I think will still remain in the realm of humans and doctors and diagnosing clinicians, not just doctors, for many, many years to come. And I find that quite exciting. I think that's good, and I don't see that the doctors being replaced in any of that. How's that future sound to you, Gandhi?
I mean, we're a bit more tech happy, I think, than most. I definitely agree with that. I would say that, you know, having an aid memoir to support you within your consultations, and definitely one that's integrated with the clinical systems that we use. I think that's the key element with it, because then it can potentially pass over data like blood test results, previous investigations, those kind of things that can add to that kind of stuff and take that information. So, you know, if a patient has a high platelet that you haven't immediately picked up on, but then when you combine that with the other kind of symptoms they're commenting on, is actually more relevant because they've got that high platelet count. You know, those kind of depth of metrics, and then presenting that in a, have you considered this, and this, which are potentially more possible because of these elements. I think having that kind of supporting tool would be clearly useful to primary care, but also to remember that that kind of thing shouldn't be then be used punitively, because at the end of the day, again, common things are common. You know, you need to rely on the fact that, you know, 70, 80, 90% of the time, it's going to be the common thing. So that shouldn't then be used punitively if it ends up being one of the more rarer things that, you know, you haven't immediately considered. But then what you would hope is that you would consider those things a lot earlier in the process.
Yeah, and I think you know, if the interface is good and it's clear what the guidance means and there's good training about it, I think it should be supportive for doctors, really, and often, and potentially even defensive. You know, I didn't think about this because it was, you know, I didn't think about it because of my experience, but also it was not, you know, suggested by the algorithm. Yeah, there could be a defensive element that could help doctors feel more comfortable as well. I was going to add, I think it has to be integrated with the clinical records system, but wouldn't it be great if it was also integrated with data collected from, you know, their smart devices? Perhaps if we ever overcome some of the governance obstacles that might be there for sequencing people's genomes and, you know, knowing what medications might work, might not, what their genetic predispositions are. If all of that, you know, if all of that information can be combined, think how great this could be. Very exciting, I think.
Yeah, I mean, the genomics element in particular obviously has massive implications, because then those more rarer genetic conditions that we never see, you know, we see once in the blue moon, that kind of thing, they become more of a potential consideration. And that's where, you know, coming up with those much, you know, those uber rare conditions, potentially we may get better, because unfortunately that's one of the things that general practice is always, and the NHS as a whole is always criticized about, that we're not so good at picking up on the you know, the really rare stuff. Part of the reason is that we don't see it. Is this a potentially an option to help with that? I think so. It does need to be done right, and integration needs to be at the heart of it.
But really, really exciting. And it got me thinking, Andy, as well. We're being a bit philosophical here, but I was wondering, so to what extent has healthcare really been touched and improved by information technology so far? Because I sort of think we do so much, you know, it must have made such a huge impact. But then you look at other professions like accounting, and I sort of feel almost they've had their spreadsheet moment. So, you know, accounting is just so different, you know, after you've got a tool like the spreadsheet. You know, that particular tool, you know, has revolutionized how looking at finance and figures and those people who work in that world work. And maybe they'll have another moment in the future where there's something as revolutionary as that comes along. You know, and publishing and other industries have had their moment. And I was just thinking, has medicine had that moment yet? Because it still feels very, very traditional in terms of actually what clinicians do day to day and the sorts of tools they're using. You know, we have access to more records, but it's a bit like having the written record, only a little bit better. I'm wondering if, you know, is this a spreadsheet moment for coming? Not right now, but do we have a spreadsheet moment coming where we get our, you know?
Yeah, we kind of had our first foray into that post-COVID. You know, COVID came along and basically just blew everything apart, didn't it? And particularly remote access to you know, clinicians and all the other kind of stuff has you know, exploded in that respect. I actually think proper integration will be the spreadsheet moment for me, because then all the other stuff comes from that integration. So when we have, the Uber thing, the unicorn thing, I think in general practice is the unified patient record. Once you have that, you've got the relevant information that you can trust and use, and that will allow all the other stuff to come from that. But until we get to that point where we have a unified patient record across all the different areas, so primary care, secondary care, tertiary care, population health, genomics, all that kind of stuff, that's when we will hit that spreadsheet moment in general practice.
Exciting. I might have invented a phrase there, the spreadsheet moment. I'm not sure that's been said before. Oh well, you heard it here first.
Yeah.
So that's the story. So Gandhi, what are we talking about next?
So, we talked about, just now about this whole concept of the spreadsheet moment. Where can people find out about these things? Where can people learn about these kind of things? Well, how about attending a conference where we can talk about the different aspects of digital health and digital primary care, and what primary care can really do when tech supports it? That would be nice, wouldn't it, Andy?
That sounds good, Gandhi. Tell me more.
Well, we're proud and really keen to share with you our idea of this. So we are launching something called the Digital Primary Care Conference, or Digital PC20 as the hashtag will be. So this is on the 30th of September. And if you're interested, feel free to check out the link that you can see on the screen, or definitely check out the show notes and stuff, because the information will be there as well. But we are effectively bringing an online conference where we are supporting primary care with the digital tools that it needs. And we will be showcasing various different aspects of this. In addition, we're going to have some amazing keynote speeches, particularly delivered by Dr. Minal Bakai of NHS England/I, where she's going to be talking about digital first primary care. We have a keynote from Dr. Nikki Kanani, who's the Director of Primary Care, talking about the future of general practice. And we've got so much more stuff that we're going to be including in that. In fact, we're not releasing all the information just yet. We're keeping you on a little bit on a tenterhooks as we confirm the last few speakers and stuff. But we've got some awesome content that's going to be coming, and Andy's just showing it on the stream, so I'm going to pop it up. If you go to that link, that's what you'll see. This is our sign up page and stuff, and we're releasing it now for super early bird sign up and things. By doing so, you get access to the conference on the day, so the 30th of September, 9:30 till 3:30, with the actual kickoff at 10 o'clock. And obviously, as per our normal stuff, you'll get access to recordings. We've got some fun little things that you're going to get in a conference pack at the end as well. And we're going to add a lot more content over the coming weeks. So even though the agenda looks full, actually, we've got lots more to add into there. And we also recognize that because it's an online conference, you're going to need breaks as well. So don't worry, there's going to be plenty of time for you to relax and enjoy it properly. And we've learned lessons from various other stuff we've done, haven't we, Andy? So we did our really successful System 1 conference just a few weeks ago, which if people did want to check that out, you're welcome to do so with that link there. But yeah, I'm really looking forward to this. I think it's going to be a really interesting event.
I'm really, really excited. So the System 1 Facebook user group conference went really, really well. But we did learn a lot about using this excellent online conference platform, the Hopin platform. So it's not like a Zoom meeting. It's not like a Zoom conference. This tries to recreate the experience of a sort of real live conference for those people attending. You have a main stage, you have breakout areas where you can run parallel sessions, and we'll be doing that throughout the day. There's an expo area where you can meet some of the exciting sponsors, and we're being quite exclusive with the sponsors here because they really have to add value in their own right as being relevant for digital primary care, and for those sorts of decisions being made by CCGs, individual practices, PCNs, about what kind of products and directions to go in. So the sponsors themselves, a lot of them could, they could be speakers, to be quite honest. So we've got some really high quality sponsors. And there's also a networking area where you can, it's a bit like chat roulette, but you can get that networking experience that you get at a live conference, and you can be matched with people to talk to and have spontaneous conversations with. So it's a really, really amazing platform. Absolutely excellent. I also think the confirmed headline speakers are absolutely top notch, with Nikki Kanani and Minal Bakai. Absolutely fantastic.
Mm-hmm.
Then we're aiming to look at the logo. We're aiming to provide content in sort of these areas. So sort of clinical elements of digital primary care, some of the communication, patient to doctor, doctor to doctor within organizations, how we manage our organizations, and also produce those people working in the digital medical education space as well. So we're currently pulling together the finer details, but this should be really, really good. And so Gandhi, doesn't that sound like such an amazing conference, and people can do it from the comfort of their own consulting room or their own home? So how much would you expect to pay for this fantastic opportunity? I think this is actually a bargain.
Yeah, if you were attending this face-to-face, the average kind of cost for a conference like this, you're talking upwards of 150 to 300 pounds of stuff that we've seen. We're offering this, the super early bird rate is £15. I mean, yeah. I don't know what else to say to that. That is bargain from my perspective, from any perspective, and that obviously gets you access to the recordings as well. So one thing to point out, that there is actually more content than most people will think. I could never attend all of that in one go, and we recognise that. So that's why the recordings will be available to everybody afterwards as well. So that if there are parts that you wanted to attend but wanted prioritised on something else, don't worry about it. You will have the ability to check in with that. And actually, if there's bits that you thought that was super amazing, I really need to revisit that so I can remember it, again, you'll have access to recordings straight away afterwards. And one of the other things that we learned from our previous sessions as well is that there's so much richness in the information you get from the chat and that kind of stuff, and questions that don't always get answered. So all of the people that are going to be working with us for this, one of the things we are asking is that those questions that we get from those chats, that we will have those answers available to you after the event if we're not able to cover everything in one go, because time is a challenge sometimes. So therefore, having all that stuff available afterwards is going to be there, and we're keen to make sure that happens for you.
Yeah, so 30th of September, 9:30 a.m. to 3:30 p.m. £15 super early bird ticket. The price will go up at some point, gets you full access to all of the recordings afterwards. We're looking forward to seeing as many of you there as can make it. It's going to be fantastic. Really excited.
Definitely. And as I said, we've got some awesome speakers lined up for you. We're just waiting for them to confirm, because we want to make sure that we definitely can deliver on what we're hoping to offer you and stuff. So yeah, there's a couple I think that are going to surprise people, and really just looking forward to that stuff. Yeah,
excellent. So Gandhi, that's great, and that's something available globally to our global audience. But we've also rebooted something that's a little bit closer to home for us. It's probably worth a quick mention for our audience, particularly those people in the East Midlands area. So so before lockdown, before COVID, we'd started getting a local sort of mastermind, local group up and running for health innovation in our area, which is Nottingham and the wider East Midlands area. And then COVID came along, and nothing was happening face to face, and everybody had a lot to deal with. But one of the interesting things about COVID is there's been a real focus on technology and innovation, and really rapid innovation. So lots of people have done lots of things, and we now are in that position where we need to talk about, digest, decide what to keep, how to move forwards, how to keep the momentum. And we think it's important that there's a forum for this to happen. It's a neutral, independent forum allowing people from different organizations to collaborate on these topics. So we have rebooted Health Innovation East Midlands. Do you want to tell us more, Gandhi?
Yeah, so effectively we're planning this for the 8th of October, and it's our kind of like local event to try and support the innovation of health within our area. So it's not just limited to general practice. This is the wider things. I mean, we had some amazing events before COVID happened. We had people talking about we had medical students talking about their innovations that they were planning with others. We heard about how the local digital landscape was changing in Nottingham, and to support patients and things in terms of unified access to records and that kind of stuff. So we had some really interesting prospects and ideas.
And I would say, sorry to interrupt, Gandhi, I would say we had a real interesting mix of people as well. So we had a number of students and people of all ages, medical students, but also media students from Nottingham Trent University who were just kind of interested just generally in the topics. We had people working in sort of investment and entrepreneurship, and people who actually invest in startups and in innovations, people who are designing and building the local digital infrastructure around healthcare, psychiatrists, GPs, other medical specialities. So it was really, really diverse, and it was a shame that we had to put it on hold, but it is starting again. And I'm really excited about the 8th of October. And obviously it's digital. Which platform are we using, Gandhi? Did we decide to use Zoom?
Yeah, so for this one, we're going to be using Zoom just because it's a more linear kind of content, but also it's a bit easy to dial into in that respect, and open. So, one of the key things we're looking for is this element of discussion. And I think one of the things that we wanted to start off, so since this is following our digital primary care conference, we thought a really good topic to talk about is the future of primary care and health in itself. So that's one of the main things that we're going to be talking about, as well as, like I said, hoping to foster and build again this local community of health innovation within our area. I mean, you're welcome to join us if you're coming from outside of the East Midlands area. Obviously this is going to be online, so the physical aspect of it is no longer an issue, but we thought that this is going to be a nice and opportune time for us to continue to support our local efforts and work and stuff, and we're hoping that we will see some really positive stuff come out of this.
Yeah, visitors welcome. Come and visit us from another area and tell us what's happening in your area. Why not?
Definitely.
Good. So fantastic news on those up and coming events. Really interesting story that we went through. Enjoyed talking about that this morning with you, Gandhi. Is there anything else that you were wanting to cover before we close?
Yeah, I think just one thing to mention to our eGP learners. So obviously Andy and myself have been working quite hard. We've been going live every couple of weeks. We've been producing a lot of content throughout in between and stuff. So just to let you know that for a couple of weeks, we're just taking a little bit of a break. So next week and the week after, and particularly the live episode. And the main reason for that as well is that the next time we would go live is actually the bank holiday weekend. So we appreciate that there may not be as many of you joining us, but also, we kind of felt we needed a break before we ramp up heading towards our digital primary care conference, as well as all the other stuff we've got planned for September, October, and onwards. So just a quick little side note that for the next couple of weeks, there won't be an eGPlearning Podblast episode. Some of the stuff I do for the eGPlearning, that may continue as well. We'll see how that goes, but temporarily we are just taking a brief break. So not to worry, we're not going away anywhere, but we're just pausing so that we can catch ourselves up. And
it's only 1 or 2 episodes at the end of the day. We're not away for the whole summer, but we just need to recharge batteries and make sure our families are still there and happy with us and so forth. So it's great, but I'm sure everybody will understand that. Right, it was great talking to you again, Gandhi, on a sunny Saturday morning. Hopefully you enjoy the rest of the day.
I know, it's pretty gloomy down here. So I'm actually in a different location. I don't know if people realise I'm down in London at the moment. And surprised my kids haven't already interrupted us a couple of times as it is, but hey, doing well. But yeah, really enjoyed it again. As always, eGP learners, if you want to contact us, both Andy and myself available, whichever platform you prefer, Twitter, Facebook, LinkedIn, yada, yada, yada. And I guess as always, eGP Learning is here to help save you and your patients time taking out in primary care and learning. And we'll catch you next time.
Goodbye, guys, and subscribe.
Yeah. Oh, yeah.